Hello, thanks for watching this video. In today's video, we're going to be discussing Charcot Marie Tooth disease, also known as hereditary motor sensory neuropathy. So first, let's begin, like always, with pathophysiology. This is an autosomal dominant condition. It's not a specific disease, but rather it's a spectrum of diseases that's related to the myelin sheath. So it's primarily going to be a peripheral nervous system condition. And so what is a myelin sheath? Well, or the myelin in general, the myelin is something that's produced by the Schwann cells to wrap around the nerves, and this increases the nerve conduction velocity. Charcot Marie Tooth, CMT, there's 1 to 7 different types, depending on the different types of mutations that are there. So the mutations can range anywhere from the production of the myelin to expression of the myelin. So depending on which one it is, it gives you a different type. So now let's talk about the different types of muscles that are involved. So here's the muscles of the lower legs. That's going to be a frontal view and a lateral view. The two main muscles that are involved are going to be the peroneal muscles and the tibial muscles. And these muscles, you have peroneus there, tibial anterior, and the peroneus brevis. So right now I'm going to be kind of coloring the peroneus longus. And that's in the anterior, and here is the lateral. So you can see that where the damage would occur. And there's the tibial anterior that I'm going to be kind of shading in there. And here is on the lateral side, I'm shading it in. And finally, let me just shade that in. And then finally we have the brevis. So you have the brevis laterally there. And you also kind of have this muscle. The longus can also be affected. So generally what you'll see is these areas of muscles that are affected, it's going to be in the front of the leg and the side, and so it tends to affect this ankle area primarily, the ankle joint. And as this muscle atrophies, you can see the front of the leg will look much thinner, and the bulk on the right side of the leg, on the lateral side of the leg, looks much smaller as well. So that's the general muscles involved. There could be other muscles involved, but these are the primary two muscles that kind of have pathologies. Okay, so that's the pathophysiology. Let's focus on the clinical aspects. This does tend to be asymptomatic. Up until about 2 years, that's when you start seeing symptoms. And these symptoms are related to being clumsy, falling and tripping over. This could be primarily due to the proprioceptive, because it is sensory neuropathy, so proprioception is going to be affected. And also because of weakness of the ankle, it tends to make them trip and fall often. So let's first look at the motor symptoms here, motor type of problems here. We have 4 pictures here, each showing a different type of issue related to the muscles. The first one here is going to be the stork leg. Feet, but legs here. So the stork leg, and so you can see that because of the peroneus and the tibial muscle atrophy, you can see that the leg in the front and on the lateral sides are much thinner. So we call that a stork leg appearance. Next we have the pes cavis, and so this leads to sprained ankles often. And so what you can see here is that normally you should have a flat foot here, but it tends to kind of stop here and then arc. You have this high up-reaching arc that you find there. The next thing that you can see here, you can see these deformed toes. These are called hammer toes. And finally we have claw hands. And claw hands occurs because you do tend to sometimes get contractions of the upper limb as well as the lower limbs here. So both of these can be found in Charcot Marie Tooth syndrome. And so these are the motor type of syndromes. What are some of the sensory syndromes that you can find? First is that you can get paresthesia. And this is generally due because when you get low muscle mass, this makes it easier to compress the sensory nerves, and so you tend to get these paresthesia. Pain-wise, there's actually decreased pain, and this is because you have an increased pain threshold as the spinal thalamic fibers get involved in this condition. And finally, you have the decreased proprioception and vibration with the dorsal column fibers, because they are myelinated fibers, and so they do get affected as well. And this explains some of the clumsiness and the gait abnormalities that are sometimes seen. So generally, this is a progressive disorder that goes on throughout their life. However, they do have a normal lifespan, and they are ambulatory, so which is good news. There are some things that can exacerbate it. Primarily, these drugs can increase it, such as vincristine and anesthetics, and also during pregnancy, it also can be related, and this is generally thought of because of the progesterone effect. Finally, let's take a look at investigations. So which investigations you're going to want to do. Nerve conduction velocity, obviously the motor and sensory are going to be decreased by, their velocity going to be decreased by 60%. And again, this is going to make sense because myelin tends to increase conduction velocity, and since you don't have that, you're going to experience a decrease in that. Next, you can do a sural nerve biopsy. The sural nerve is found on the back of the leg, back of the calf, and so you take a biopsy from there. This is pretty diagnostic. And so here on the side, you can see we have a biopsy of the sural nerve here. And so if you look at the arrows, here's one and there's another one, you can see that the area around the nerve is thickened, and that's the myelin sheath that you're seeing there, the Schwann cell. And so that's called the onion bulb effect. Beyond that, you can also do some genetic testing, which can detect it. And this can also be detected, antenatally using chronic villus sampling. And you can, and this genetic test can be done off of the blood, doesn't necessarily need to be from the muscle. Finally, creatine kinase, EMG muscle biopsy, generally not necessary because this is more of a nerve issue, not a muscle issue. So these will usually not show any major findings. Management, how would you manage this condition? Again, there's no real cure, so you're probably primarily going to focus on supportive, and again, these people tend to live full lives. The diaphragm is not affected like in other muscular dystrophies or neuromuscular disorders. They tend to pass away because of respiratory failure, but here, since the diaphragm is not affected, we don't tend to have respiratory failure. So the first thing that you want to do is you want to focus on orthotics. And what orthotics allow the patient to do is stabilize the ankle. And you do this by giving these stiff boots, which go about mid-calf, and it provides the ankle with support to prevent the pes cavus that you may see and other symptoms that arrive from the ankle. The other thing that you can do is you can start with physiotherapy. You can try doing stretch exercises, and this can help decrease the frequency of ankle fractures. Finally, if you get severe, surgery is an option. Primarily ankle fusion is what they tend to do. And as far as management, you do want to avoid some drugs. Like we talked about earlier, there are certain drugs that can increase the progression of the disease. The first one being vincristine, also some antiepileptics, phenytoin, carbamazepine. These tend to affect more of the sensory side, not necessarily the motor side. And finally, anesthetics, because they oftentimes do affect the muscles and the nerve fibers. It's still questioned, but it's generally better to avoid them. Thanks for watching the video. See you in the next one. Bye-bye.